Welcome to further exploration of the work-health relationship, Spotlight on Health Affairs Special Issue. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. We thank our program partners, Pain BC, Explore Chronic Pain Work, Canadian Council on Rehabilitation and Work, and our Education Advisory Committee and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed the direct links for all of these items when they're available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Kimberly Jeanette. Dr. Jeanette is president of the Center for Workforce Health and Performance, an affiliate faculty at the UCSF Institute for Health and Aging. Dr. Jeanette has studied and practiced in the health and well-being field for more than 3 decades, including at RAND, the Department of Veterans Affairs, and the Integrated Benefits Institute. Dr. Jeanette received a doctorate in public health and sociology from the University of Michigan, Ann Arbor, and her Master's of Science in Public Health from UCLA. And now I'll hand it over to Kimberly.
Thank you, Angie. Hello, everyone. Thanks for joining the webinar, and thank you to WWDPI for hosting it. Angie's already given a little introduction. I'll give slightly more. Our organization, the Center for Workforce Health and Performance, which we call CWHP for short, is a not-for-profit research and educational organization focused on workforce health and performance improvement. And our aim is to pull together and translate research for a variety of practical and applied audiences. In addition to conducting primary research around the work-health relationship, we point toward others' research, and we try to pull in the best practical applied research that we can and encourage that. And you'll see at the end where you can submit your ideas, and we really encourage participation. Today, I'll be presenting on a special issue of Health Affairs from February of 2017 that's devoted to the relationship between work and health. I'll describe the dozen published papers and their findings, and some of the research I'll present was conducted while I was at the Integrated Benefits Institute, and you'll see mention of several other sources of evidence as well. Let me tell you a little bit about that special issue. It was a special issue sponsored by IBI and some of their members, Sedgwick, United Health Group. We had additional support for policy briefings from Pfizer and Pinnacle Assurance. And there's information on IBI's website as well as the centers, and I'm happy to follow up afterward with more information for those interested. In February of 2017, IBI and some of its members sponsored this issue because Health Affairs is a leading health policy journal, and we wanted to give more visibility to the relationship between work and health and to the evidence base that is growing and for which we know that there was good research that could be done and that needed to be disseminated. We are continuing to follow up with the authors of these papers to highlight their work in ways that resonate with a variety of audiences, not just researchers. And this translational work includes a series of briefs. Here's the screenshot of the first one that spotlighted organizational culture and climate. We'll get to each of these sections and talk about them, and we'll continue to have publications, convenings, and educational opportunities around these authors and others around work and health. We've decided to bucket the evidence into 5 areas, topic areas. We could have done this in many ways, but we decided to have it flow. What we think is a rather natural flow here from prevention and wellness to start to what seems to be the overwhelming area we focused on, which is health intervention or intervention through the medical treatment system in terms of improving worker health. There's also the third area of supportive work intervention, and a couple of the papers focused more on that. We have a number of papers, I'd say almost all of them, have something to say about organizational culture and climate, and so we focus on a few where that was more of a central topic in the paper. And then finally, a couple papers that focus more on public policy interventions. And I'm going to briefly highlight some of the findings from the dozen papers that fall under each of these topics and summarize some key takeaways from our perspective on this special work health issue. Rarely, of course, do these papers fit nicely under each of these headings. They tend to cross them, but we've organized them to represent the thrust of the article. And we'll also focus on the importance of developing, sharing, and using evidence, not just creating research papers, and talk about the various perspectives for improving employees' health and work performance. So let's start with our first topic at the beginning with prevention and wellness. Currently, most of the dollars spent on health in the current U.S. healthcare system, about which most of the papers are written, are focused on healthcare service delivery and disease management. And our system does tend to focus on treating disease, sickness, injury, and infirmity without due attention to preventing these conditions and events from occurring. We tend to overemphasize the importance of disease management because we often feel powerless against the array of risk factors, both individual and structural, that emphasize either personal responsibility or socioeconomic factors seemingly outside the control of organizational action. But by most accounts, and depending on the specific condition one might assess, healthcare produces between 10 and 20% of health. Other factors like genetics and biology, health behaviors, social and economic factors, and the physical environment account for the other 80%. The bulk of what produces health is not related to the provision of healthcare services, but that does not mean that health care is not important. Rather than pitting one cause against the other or one factor against the other, we need to embrace the ways in which these factors interact with each other and affect health outcomes at both the population and individual levels. And the wellness industry focuses on prevention, typically, but often on a single slice, health behaviors. We're going to present some work here where the wellness industry is expanding and changing their focus to also incorporate a broader array of factors. Paying attention to socioeconomic and other factors can make a big difference in protecting worker health, as suggested by several papers in this special issue. For this particular topic, prevention and wellness, I'll cover two of the papers. So one of the papers was written by Bruce Sherman and colleagues, and what they talk about are the trends that demonstrate that employees face an increasing financial burden for health services as healthcare costs increase relative to earnings of employees. Little is known about healthcare utilization patterns relative to employee wages, and some of that has to do with the separation of databases in the U.S. between data that contains information on employees' job context and wage earning, and data on their healthcare utilization patterns. To better understand this association and the resulting implications, these authors examined patterns of healthcare use and spending by wage category during 2014 among almost 43,000 employees of 4 self-insured employers enrolled in a private health insurance exchange. And this allowed them to obtain information on both wage for those employees as well as their healthcare utilization. When demographics and other characteristics were controlled for, employees in the lowest wage group had half the usage of preventive care, nearly twice the hospital admission rate, more than 4 times the rate of avoidable admissions, and more than 3 times the rate of emergency room visits. These findings provide new insights about wage-associated variations in healthcare use and spending in employer-sponsored plans. And for policymakers, these findings can inform employer benefit design strategies and research priorities to encourage effective use of healthcare services, including greater use of preventive services, particularly among individuals in the lower wage bands. Another paper that focused on prevention and has broader implications is research coming out of a tradition around how job loss can cause illness and premature death. So there is a lot of extant research available on the relationship between losing a job and health effects. And this body of research raises the question of whether unemployment benefit programs, which are intended to alleviate the financial stress of job loss, can protect the health of the unemployed. To investigate this question, these researchers analyzed data for the period of 1984 to 2009 using the panel study of income dynamics data, a publicly available data set in the U.S. They found that receiving unemployment benefits significantly reduced the probability of reporting poor health in the year after job loss by around 5 percentage points. The health promoting effects of receiving the benefits were robust across multiple model specifications, and after they accounted for pre-existing differences between benefit recipients and non-recipients. So these study results add to the growing body of literature that suggests that social policies can have unanticipated health effects, including preventative results. So we'll turn to the second section on supportive health interventions. There is a tendency, as I've mentioned, in our current system to focus on claims costs and how much ill employees are costing companies in medical and pharmacy treatment costs. In this section, we highlight a couple of papers that focus on the broader benefits of employee health and health intervention to employees, employers, and society. Work holds the promise of supporting and promoting health. This paper by Bob McClellan is an excellent overview paper across a variety of issues, and I strongly recommend it for anyone who may be new to the research in this area on the connections between work and health. If you go to the site and you aren't a Health Affairs Journal subscriber, this would be a great paper to download. And as he notes, work can promote and support health. There's been a lot written about that, and we have some on our website about that as well. But work also carries the risk of injury, illness, and death, in addition to harms posed by traditional occupational health hazards, such as physically dangerous workplaces. Work contributes to health problems with multifactorial origins, such as unhealthy lifestyles, psychological distress, and chronic disease. Not only does work affect health, but the obverse is true. Unhealthy workers are more frequently disabled, absent, less productive, and they use more healthcare resources compared to their healthy colleagues. The costs of poor workforce health are collectively borne by workers, employers, and society. So for businesses, as well as for altruistic reasons, employers may strive to cost effectively achieve the safest, healthiest, and most productive workforce possible. Narrowly focused health goals are giving way to broader concepts of employee well-being. And this article explores the relationship between health and work, outlines opportunities for employers to make this relationship health promoting, and identifies areas needing further exploration. Another article that we would categorize under this topic around health intervention is research by Dr. Gifford of IBI that relies upon a commercial database representing multiple employers and containing both medical and disability claims data. Having both types of data allows the researcher to look at the connections between use of healthcare services and outcomes such as short-term work disability or long-term work disability, periods of disability from work, and the costs associated with those disability leaves. This study found that about 1 in 4 employees in a cohort of about 400,000 U.S. workers took a temporary leave of absence from work because of illness or injury in the period of 2008 through 2012. These workers accounted for nearly 60%, about $6.5 billion of total worker health care and disability payments. And this finding underscores the importance of workplace care management, lifestyle management, and health and safety efforts to prevent disability leaves, the importance of an integrated approach that doesn't just look at medical and pharmacy costs, but also looks at the impact in the business of a variety of leaves, not just disability, but also sick leave, absence, family medical leave, and other types of leave are implicated, although not studied here, certainly implicated. So let's get to our third topic around supportive work intervention. We've talked so far mostly on the health side of preventing conditions from occurring, changing lifestyles, looking at medical claims utilization and how we can more broadly look at the relationship between chronic disease and broader outcomes at work. But there certainly are interventions that employers can implement in a workplace. And rather than seeing the health of employees as entirely related to personal choice or mostly remedied through the healthcare delivery system, innovative employers know that work environments, relationships, policies, and the nature of work itself can make a big difference in the health outcomes of workers. So we focus in this section on supportive work intervention. So one of the studies I put in here is the paper we authored in the special issue, and our paper focused on the importance of physical and cognitive job demands on productivity as measured by the outcomes absence and presenteeism. And we had a database of workers' comp claims data from Pinnacle Assurance that we were able to map and link at the individual level to responses on a survey around a variety of chronic health conditions, as well as the occurrence of sick leave, absence, and what we term presenteeism, which presenteeism occurs when an individual attends work while ill or injured. And in this paper, we examine the influence of workplace safety and employee health in relation to job demands across approximately 17,000 employees working for over 300 large, mid-sized, and small businesses in the state of Colorado. These data, as I mentioned, come from a Pinnacle Assurance study launched by the workers' comp carrier to focus on how they might influence injury events by better understanding the connection between these workers' comp claims and non-occupational injuries and illnesses. As part of these efforts, a health risk appraisal, including health and work outcomes information, was administered to the employees who participated in the worksite wellness program offered by the carrier. And we found that both workplace safety and employees' chronic health conditions contributed to absence and job performance, but their impact was influenced by the physical and cognitive difficulty of the job. If employers want to reduce health-related productivity losses, we argue they should take an integrated approach to mitigate job-related injuries, promote employee health, and improve the fit between our workers' duties and their abilities. We plan to further analyze these data around work stress and variation in outcomes across setting. We believe that the importance of workplace factors, as we'll show in further studies in these issues as well, have the potential to mitigate, greatly mitigate the health effects of illness in the workplace. Another study we have under here is Ceci, Burry, and colleagues' paper on the racial and ethnic differences that he found in terms of workplace injuries. And what we know from the literature and the research is occupational injuries and illness lead to significant healthcare costs and productivity losses for millions of workers each year. This study used national survey data to test for differences between members of minority groups and non-Hispanic white workers in the risk of workplace injuries and the prevalence of work-related disabilities. Non-Hispanic Black workers and foreign-born Hispanic workers worked in jobs with the highest injury risk on average, even after adjustment for education and sex. These elevated levels of workplace injury risk led to a significant increase in the prevalence of work-related disabilities for non-Hispanic Black and foreign-born Hispanic workers. These findings suggest that disparities in economic opportunities expose members of minority groups to increased risk of workplace injury and disability. Some attention to these differences are suggested in terms of CES work and other work that we'll cover. Another paper in this is Victoria Blinder and colleagues' paper on women with breast cancer, also looking at income levels and minority status. Breast cancer affects 1 in 8 women across the United States, and low-income minority survivors of breast cancer are at increased risk of job loss compared to higher income white survivors. Employer accommodations, which include things such as schedule flexibility, have been associated with job retention in higher income whites, but the role of such accommodation in job retention among low-income minorities is not as well understood. These researchers conducted a longitudinal study of 267 employed women between the ages of 18 and 64 who were undergoing treatment for early-stage breast cancer, and these women spoke either English, Chinese, Korean, or Spanish. They categorized patients by income level and by race and ethnicity. The category with the lowest job retention after treatment was low-income women at 57%. Job retention varied widely by race and ethnicity, ranging from 68% among Chinese women to 98% among non-Latino whites. Women who had accommodating employers, those that offered more schedule flexibility, were more than twice as likely to retain their jobs as those without accommodating employers. Low-income women were less likely than higher-income women to have accommodating employers, however. So more uniform implementation of accommodations across low and high-paying jobs could reduce disparities in employment outcomes among workers with a cancer diagnosis. Additional research, of course, needed to better understand the barriers that employers may face, particularly those with a higher proportion of low-income workers, in providing such accommodations. So we'll get to, probably without exception, the category where most papers mentioned the importance of organizational culture and climate in terms of impacting employee health and performance results. And in this section, we'll focus on a few papers that emphasize this theme as a core in their research. This study is by David Repkoff. He is a physician researcher at Stanford, and they acknowledge that studies on the physical and social characteristics of the workplace have begun to provide evidence for the role of specific workplace factors on health. However, the overall contribution of the workplace to health has not been considered. Estimates of the influences on health across domains of the work environment are a critical first step toward understanding what level of priority the workplace should take as the target for public policies to improve health. The influences or contribution of these domains on health in the work environment are particularly useful to study, since they are potentially modifiable through changes in policies and environment. This research uses detailed data for blue-collar industrial workers at 24 Alcoa plants. It includes work environmental measures of psychological hazards, physical hazards, and the workplace social environment to estimate the overall importance of the workplace environment for hypertension. The study findings suggest that social, psychological, and physical aspects of the work environment could contribute to a substantial proportion of hypertension prevalence. These attributes of the workplace could thus be a useful target for improving workforce health. Another study in this area is one by Jean Abram and Katie White, tracking the changing landscape of corporate wellness companies. The corporate wellness industry is diversifying and now includes legacy wellness companies, divisions of health plans or delivery systems, and new technology-focused solution enterprises. These researchers conducted in-depth interviews with leaders in the industry to understand the changes in its supply side, the drivers of these changes, future trends, and their implications for employers and policymakers. Three key trends emerged from the interviews. The industry is expanding and becoming increasingly diverse and competitive. Second, wellness companies are redefining their business models to promote a culture of health. And finally, the value proposition of employee wellness programs is shifting from the idea of return on investment to a new idea, value on investment, looking at broader outcomes than simply medical and pharmacy cost reduction. These findings clarify wellness companies' innovations, their contributions to population health improvement efforts, and the need for additional evidence to demonstrate the value of the new generation of wellness products and services. And as with the earlier paper I mentioned, that's a good overview. This is another one, if you're in the wellness space, I would highly recommend downloading and bring you up to speed on what some of the latest trends are. Another paper, third paper under this general topic of organizational culture and climate is by Ron Getzl and colleagues. And this study provides a preliminary snapshot of how the comprehensiveness of workplace cardiovascular health interventions is related to measures of employees' health risks, disease prevalence, and medical expenditures. The study authors link scores for 20 large organizations that voluntarily completed the American Heart Association's newly launched Worksite Health Achievement Index, or WHAI for short, in 2015, and it links that to individual level market scan data for 300,000 of their workers, almost 400,000, 373,478 of their workers with employer benefits that year. So an interesting study linking that WHAI information to the market scan data. And market scan data, it contains claims information, health and pharmacy utilization information, as well as health risks that may not be captured in WHAI. Higher aggregate WHAI scores were associated with lower values for 4 of 7 modifiable indicators of cardiovascular risk, and a higher value for 1. Although also associated with lower prevalence of cardiovascular disease, higher aggregate scores were associated with higher spending on the condition. These and other findings provide useful benchmarks and norms for employer practices related to cardiovascular disease prevention and suggest a potential for linking aggregate measures to other disease prevention programs. As employers continue to complete the annual WHAI, the authors expect to gain further insights into the policies, programs, and environmental supports employers can implement to positively influence cardiovascular health and related spending. So this is an effort to try to map together aggregate with individual outcomes, aggregate information around policy and supports with individual outcomes. We'd like to see more of this kind of work and deeper work that gets into the relationships and the effects as well, in addition to the value of benchmarking. So finally, I get to a couple papers in our fifth and final category, public policy. And I'm excited to present these because a couple of the topics aren't what we normally would maybe present under work and health, and I think they're somewhat undervalued and on the margins because as researchers we tend to use the data that's available, and so I'm very pleased that we had researchers who pulled in non-traditional data sets and allowed us to feature in Health Affairs, a leading health policy journal, some very important issues connecting worker health and well-being. The first paper I'm presenting is one by Douglas Leslie and colleagues. It's on Medicaid waivers, but the broader topic is really, we know that employees as caregivers for family members often take time off work to deal with the health-related needs of their family members. So whether that's a parent with dementia or a child with autism, there are health-related factors of being a caregiver. If you're an employee, you may have presenteeism on the job to try to deal with it. You may need to take some time off, and unfortunately, sometimes you may need to stop working in certain cases. And so these researchers wanted to look at the Medicaid waiver program because several states had passed Medicaid home and community-based services waivers that expanded the eligibility criteria and availability of services for children with autism spectrum disorder. And although previous research has shown considerable variation in these waivers, little is known about the program's impact on parents' workforce participation. These authors used nationally representative survey data combined with detailed information on state Medicaid waiver programs to determine the effects of waivers on whether parents of children with autism spectrum disorder had to stop working because of the child's condition. What they found is increases in the Medicaid home and community-based services waiver cost limit and enrollment limit limits significantly reduced the likelihood that a parent had to stop working. And although the results did vary considerably by household income level, these findings do suggest that the Medicaid waivers are effective policies to address the care-related needs of children with autism spectrum disorder, and I would argue have implications for other kinds of caregiving needs that individuals may have, and may point toward experimental policy solutions in other areas as well. Another paper in this area focused on the shifting landscape in the connections between work health and insurance, and these researchers examined the interrelationships and what has been affected by the changing demographics and employment conditions in the U.S. in terms of the interrelationships between work health and health insurance. Stagnation or deterioration in employment conditions and wages for much of the workforce has been accompanied by the erosion of health outcomes and by the erosion of employee-sponsored health insurance coverage. In this study, the authors present data and discuss the research that has established these links and assess the potential impact of policy responses to the evolving landscape of work and health, with the expansion of insurance availability under the Affordable Care Act, which may have helped reduce the burden on employers to provide health insurance. But the Act's encouragement of wellness programs has an uncertain potential to help contain the rising costs of employer-sponsored health benefits, and unintended, perhaps further action around additional research that was spawned by the ACA is with more attention on wellness potential and preventative interventions from employers. We need good evidence building and research to go along with it. We've presented some of that today, but I think there's broader implications for looking at the employment context and the employer's role, both in terms of legal and policy concerns and protections for employees and their health data, but also in terms of fostering and improving employee health and providing supports. This is a broad overview, analysis, and commentary around ACA and its impacts in a U.S. context. So if that's of interest to you, I highly recommend downloading this paper. So where are we after examining a dozen papers on the connection between work and health? What can be implemented or experimented with in a real-world context now? As a researcher myself, I certainly value ongoing research and evidence development, and almost all of the papers I've presented conclude being good researchers with the need for more research and evidence development. But I must say that I increasingly believe that we need equal, if not more, attention paid to the dissemination and use of the evidence that already exists. And I will close this presentation with some recommendations for strengthening our use of evidence around work-health connections. Let me just begin by summarizing in brief what I think these dozen papers suggest. These are not the only findings. As you've seen me cover those findings, you'll find other findings if you download the reports that may resonate with you. These are the findings that jump out at me and that I think could be useful to employers. So around prevention and wellness, we really need an increasing focus on prevention while we continue to provide access to high-quality disease management. We need to stem the tide of crisis management. We need to move our energy and our focus toward a preventive framework, and that requires us to understand multiple causes of health, not just use the tool of healthcare service delivery. It is one tool in a toolbox, and we need to have a broader understanding of how to prevent conditions from getting exacerbated to a point that it affects an individual's quality of life and inability to participate and to offer healthcare services with the patient in mind, with the employee in mind, so that their real-world quality of life outcomes can be affected. As wellness efforts become more mobile and distributed, there should be a continued focus on assessing the value generated from a more preventive orientation to care delivery. So we do need to make sure that we're not moving away from providing high-quality disease management and provide some rigor and evidence to that. I would also strongly argue, and several of the papers covered this, that we need to move away from a narrow return on investment orientation where we are only looking at the healthcare intervention without understanding the broader outcomes that matter to those who ultimately are supposed to benefit from these interventions, which are the employee and the employee's health status. If the employee's health can be improved and their functioning improved, that has benefits for employers and society at large, as well as the employee being able to continue contributing as much as they want to and participate in the labor force. In terms of supportive health intervention, I would argue that improving access financially and physically to high value treatment for both workers and their family members will contribute to reductions in work loss. And whether those measures are presenteeism or work disability or absence, caregivers as well as workers can benefit from having access to high quality health interventions. So the importance of disease management doesn't go away, but the amount of resources that we are spending at the tail end after people have developed these chronic conditions needs to be balanced with the earlier focus on prevention and wellness that was mentioned. Work itself, in terms of providing work-related interventions, can have profound effects on the employee's health and well-being and their ability to remain in the workforce. So employers need to have a renewed focus on job accommodations and return to work practices and flexible schedules. And this should not just apply to the traditional safety viewpoint of injuries and physical accidents, but also psychosocial hazards on the job as well, which can contribute both to mental health conditions as well as we saw in the earlier paper, to chronic conditions and physical conditions such as hypertension and cardiovascular disease. We also saw in these papers, all of the papers indeed talk about organizational culture and climate, and across the board, certainly these structural and environmental effects do matter for the success of any intervention. Understanding how physical and emotional hazards in a workplace, including the relationships among workers and workers in management, affect health and work-related outcomes really becomes a major theme across many of these studies. And it demands that researchers have to be creative in understanding and using methods as appropriate to assess the extent to which structural and cultural dimensions in the aggregate are influencing individual relationships at the employee level. And there are methods for doing that, and there is evidence out there that uses those methods. And so we encourage more of that among the research community. And finally, in terms of public policy, as we have the prospect of extended working lives with the population aging and the increasing prevalence of chronic disease, it becomes even more imperative that employers understand how they can positively influence the work-health relationship. And we traditionally, from a public health point of view, and certainly in our country, the National Institute of Occupational Safety and Health, NIOSH, has come out of a tradition of having a very strong focus on safety and physical hazards. And they now, with their total worker health unit, are starting to focus on these broader effects and broader relationship and the broader social determinants of health, and how psychosocial hazards also are important. And we believe there's a role for public policies, but also for employer policies, and understanding the value of work to the socioeconomic success of workers and to businesses and society at large when we can have individuals participating in the labor force to the extent they want to. So with that, I wanted to end with a offering that we have on our website where we try to pull together the latest research We've developed a portion of the website where we try to make evidence searchable by condition and audience. We will be expanding that. We understand that employers have different interests than what we call solutions partners. Solutions partners are the array of companies out there and organizations that have interventions and services to offer. They could be health plans, health insurance companies, disease management companies, wellness providers, you name it. That's why we're calling it Solutions Partners for now. And as we get more resources submitted to this, we can start to push that out to be useful to different audience members. We recognize the audience members can be broader than just the 3 buckets we have here of employees, patients, employers, and their solutions partners. And to start, we have the categories of cancer, depression, diabetes, multimorbidity, and pain, because we recognize, at least in the U.S. healthcare system, that we have an over-focus on chronic conditions, partly because we have a very high prevalence of those conditions in our workforce and in our population more generally. But what we try to do is tie the evidence that's available on these broader outcomes and broader solutions to these chronic conditions. Multimorbidity certainly crosses most conditions. We find that many individuals with chronic conditions have other comorbid conditions. And then pain isn't a condition per se, but it certainly is a symptom. And with the opioid crisis looms large, we imagine we will have other categories over time, and we may have other ways to sort and find the research and welcome any suggestions that you have. So you can either email me directly, or you can see submit a resource at the top there. All of our information is publicly available. We are a nonprofit 501c3 organization, no membership involvement required. So please feel free to go on the site and look. We welcome suggestions on other dimensions that may be of interest, and we encourage submissions and suggestions for this resource hub. We'll be looking for more and more research that applies a systems perspective and includes broader outcomes of relevance to employees and employers. And we firmly believe that we must take a systems perspective and move away from relying too heavily on measures that are easily available, because this perpetuates the over-reliance on outcomes we are currently observing to the exclusion of outcomes we should be observing. What this means practically is that we must move beyond measuring only claims or utilization data, because these data represent current benefited users of the system. We must explore whole populations of workers and do so over time, and we must not assume that lack of utilization means lack of need. We must look at whole populations. Unfortunately, in the U.S., those charged with making employee health investment decisions for a workplace are most often asked to reduce healthcare costs, and the easiest way to do so is not to measure anything beyond medical and pharmacy claims costs to the employer. So, by shifting costs to the worker and not measuring anything beyond medical claims costs to the employer, a rapid cost reduction can be demonstrated in the near term. These are the narrow ROI arguments. But if we shift toward a value of investment, if we look at broader health outcomes measured across the population of workers, such a strategy would reveal treatment access problems among the workers and a logically related health decline over time. And since research and evidence strongly connects health to work-related outcomes like absence, job performance, and work disability, employers ought to pay more attention to worker health, not simply health claims costs. Connecting the disparate departmental silos and bringing together the health promotion, safety, and disease management functions, either in conversation or structurally, are fruitful ways for an organization to develop a systemic population-based perspective to employee health and well-being improvement for better business results. So thank you for your time. Thanks for listening to my presentation. I welcome any questions you may have at this time.